I'm Dr. Posas-Mendoza. I'm a board-certified rheumatologist, and I'm going to teach you how to interpret a positive ANA. Think of an ANA like a metal detector on the beach. Most of the time when it beeps, what you found is bottled caps or broken nails. Most of the time, you're not finding buried treasure. A positive ANA is extremely common in the general population, especially at low titers. So where you sweep matters just as much as what you find. If you wave your metal detector over every stretch of sand, you're going to spend your day digging up a lot of broken nails. If you use a metal detector only in places where you know a treasure ship has sunk, or you order an ANA in patients with symptoms that are genuinely suspicious for systemic autoimmune disease, then a beep starts to mean something. Key point: only order an ANA when you have genuine clinical suspicion for a systemic autoimmune disease. For isolated fatigue, generalized joint pain, or malaise, the test has little value. Second key point: do not repeat a negative ANA. Most repeats are unchanged, and when a negative does convert to a positive, the yield of a new autoimmune diagnosis is about 1%. An ANA titer is also not a marker of disease activity, so don't trend it. Assuming your pre-test suspicion is already high, here is how you sort out a positive result. Step 1. Is it positive or negative? The lab looks at the sample under the microscope. If it is glowing, that is positive. Step 2. Titer. How strong is the signal? The titer is how much the sample can be diluted and still glow. It's like adding water to coffee. The more water that you have to add to dilute the coffee, the stronger the coffee is. A titer of 1 to 40 is very weak coffee. Roughly 20 to 30% of the healthy population is positive at this level. This is your bottle cap. Absent a textbook clinical presentation, this is clinically meaningless. A titer of 1 to 80 is still weak. Roughly 15 to 30% of the population is positive at this cutoff. A titer of 1 to 80 is required to enter the 2019 EULAR-ACR classification criteria for lupus, but it does not gain any points, and it definitely does not diagnose lupus. This is probably a broken nail. Worth a second look, but don't assume a systemic autoimmune disease. A titer of greater than 1 to 320 is strong coffee. Only about 3% of healthy adults have a positive ANA at this titer, so it's more likely not an incidental finding. This definitely deserves further investigation, especially in a person who has symptoms suggestive of an autoimmune disease. Practical rule: a low titer with no symptoms is clinically meaningless. A titer of greater than 1 to 80 with suspicious clinical symptoms warrants further workup. Step 3, the pattern. The pattern tells you where in the cell the antibodies bind, which narrows your differential. Remember, every single one of these patterns can also appear in normal, healthy people. I'm going to talk about the most common patterns. The first is homogeneous, which some labs report as diffuse. This pattern can be seen in lupus, drug-induced lupus, and autoimmune hepatitis. Here are the things you need to consider. Does this patient have photosensitive rashes, oral ulcers, pleuritic chest pain, or inflammatory arthritis? If they do, check lupus labs. This presentation is suspicious for lupus. 2. Is this patient on a culprit drug? Are they on procainamide, hydralazine, isoniazid, minocycline, or one of the TNF inhibitors? If so, add an antihistone antibody, and if they are having symptoms suggestive of lupus, also check the lupus labs. This presentation is suspicious for drug-induced lupus. 3. Does this patient have elevated liver enzymes? If so, check a smooth muscle antibody, rule out viral hepatitis, and consider involving hepatology. This presentation is suspicious for autoimmune hepatitis. The next pattern is speckled. This is the most common and least specific pattern. Here's what you need to consider. First, is this a dense, fine speckled pattern? If so, this pattern is most commonly seen in normal, healthy people. It has no established disease association and is most likely a bottle cap. 2, does the patient have a photosensitive rash, oral ulcers, pleuritic chest pain, or inflammatory arthritis? If so, send lupus labs. This presentation is again suspicious for lupus. 3, has this patient had persistent daily dry eyes and dry mouth for more than 3 months? Have they had functional impairments like trouble swallowing dry food, parotid gland swelling, or systemic symptoms? If so, check an SSA. This presentation is suspicious for Sjogren's disease. Fourth, does this patient have Raynaud's phenomenon, interstitial lung disease, myositis, pulmonary hypertension? If so, check a U1RNP. This presentation is suspicious for mixed connective tissue disease. The last patterns are centromere and nucleolar. These patterns are most commonly seen in systemic sclerosis. Does this patient have Raynaud's phenomenon, sclerodactyly, dysphagia, interstitial lung disease, or pulmonary hypertension? If so, check scleroderma-specific antibodies. This presentation is suspicious for systemic sclerosis.